It's autoimmune. That's a question that nobody can answer, and that's a question that patients always want to know the answer. Why do I have this? What happened? And we cannot usually stop it.
Gotcha. And also for the patient, for the lady that had stomatitis medicamentosa, what do you prescribe to like treat her?
Usually, stopping the exposure depending on how extensive the lesions are, they might be palliative. Just symptomatic care and warm saltwater rinses and something and that that's usually all that's required. If it's ongoing, they've had multiple exposures and it's continuing. I usually don't think how my physician. Yeah.
So the question is, chemical and the allergy.
Right.
So those are the most picture,
Mostly pictures.
Okay.
We thought it was just the oral capture part.
It is, but the physical and chemical injuries was an oral palpable. That was the one we had last week.
And the allergy from
This one that we just finished.
Can I ask what causes the strawberry gums?
The gums is that granulomatous inflammation attacking the blood vessels, and it's routinely red too because when you attack the blood vessels, they
Yeah, okay. Trigger.
they don't know. That would be awesome. I don't have rubrics for each case, but I have an overall thing, yes. So basically our rubric are the rules for identifying critical illness. What constitutes a critical illness? Because that's, I mean, what else can we do? If you don't have it, by email, when you expect it this evening, since I'm in private practice tomorrow, send me an email to remind me.
Okay.
I have to do it today.
Once I'm done with class, I'll send you an email.
Okay.
I'll make a note of it.
I will forget.
Do you know how to use Panopto?
No, so I want to ask you, so you have to. Okay, how did you do
So
that?
if you log into Canvas,
Okay.
go to the Panopto page,
Yep.
and then create new.
Uh-huh.
It gives you a drop-down box, and it gives you a place where you can download Panopto.
Onto your Canvas page
No.
for the course or for yourself?
You have to
For the
load
computer.
it on your computer so you
Okay.
can record in the future. Once you have that, I can show you how to use that.
Let me do that then. Yeah. So when we meet on Wednesday, I'll download it for today. And then when we meet on Wednesday, you can show
I can show
me
you how to use
do it. So
It's
for
actually
next
really
week-
easy to use,
Yeah,
but you do have to have the software. You
I
do have
noticed
to
that you had an
install it.
announcement that you use the Panopto, so I said, okay, I should check with you. I made a note for myself. Ask you about it. Perfect. Thanks.
Like it's a tenure. The child is a tenure where you can just
Guys, there's a Dr. Moss class. Do we have class today? We did the same way.
Facial.
our class.
There's no class.
Well, I mean, we probably noticed that. I don't think I
Okay, everyone, have a seat.
I think your mic is off.
Yeah, I'm gonna turn it on. Okay, you guys can go ahead, have a seat. Please take a seat. Please take a seat. We're gonna go ahead and get started. Okay, we're gonna go ahead and get started. Please take a seat and no more talking. Thank you, appreciate it. Yeah, I need to really scream loud. Okay, is everyone settled in? We are going to go ahead and get started with our topic, skin diseases in the mouth. So there's a lot of entities here that we're going to talk about that are immune mediated. Just pay attention to how to differentiate these things because unfortunately a lot of these entities can look very similar clinically in a patient's mouth. Okay, so it's critical to know what is the pathogenesis, how do you differentiate it based on the pathogenesis, and what histologic features you need to look for to differentiate between these lesions. And there's some subtle clues clinically that you can utilize to help differentiate the entities that we're going to talk about. So pay attention to differentiating these lesions because of the similarities in presentation. Okay, so when we talk about immune-mediated diseases, what does that mean? So something is happening with our immune system that's basically, causing these antibodies to be produced against the antigens in the body, right? So what happens is in some of these immune-mediated diseases, you have an inappropriate production of these antibodies, and then by the patient, so they are autoantibodies, and these go and attack the different cells or different components of the epithelium as well as the epithelium and the connective tissue. So if you look at this, right? So what are these cells right here? Do you guys remember this? A little bit about histology. So is each of these, what does this represent? That's one cell, right? This is another cell. You have another cell. What is this structure? Nucleus. What is this? Cytoplasm. So the pinkish layer is the cytoplasm. The blue is your nucleus. What's this one? Nucleolus, right? So each of these cells is an epithelial cell. Now, how is each epithelial cell connected to another one? Desmosomes, right? So these lines that you're going to see here are your desmosomes. Okay. Now, this epithelium has to connect to the underlying connective tissue. So there's a basement membrane layer. So these epithelial cells connect themselves to the connective tissue here at the basement membrane level. You see these lines right there? What are those structures? Those are hemidesmosomes. So desmosomes connect your desmosomes connect one epithelial cell to another. A hemidesmosome connects basically your epithelial cell at the basement membrane level. Okay? So depending on where this autoantibody, so the antibody that's produced by patient's cell, right, goes and attacks. So if the autoantibodies come and attack the junction between the epithelial cells at the desmosomal level, you get one kind of a disease. Okay? If the antibodies go and attack at this level, at the hemidesmosomal level, you get a different kind of disease process. Does that make sense? So you have two different diseases that can manifest depending on exactly where these autoantibodies go and attack the junction of the cell structures. Okay? So if they attack the junction between the two epithelial cells at the desmosomal level, you get a disease process called pemphigus. Okay, so that's the first disease on your handout, pemphigus. If they attack at the hemidesmosomal level, you get another disease called mucous membrane pemphigoid. So that's your second disease on your handout. Make sense? So if it attacks at the desmosomal level, what disease would you see? Pemphigus. If it attacks at the hemidesmosomal level, at the junction between the epithelium and connective tissue, what disease would you likely to see? What are you likely to see? Mucous membrane pemphigoid. Okay, the reason why it gets the name mucous membrane pemphigoid, when you say goid, like, right, oid means it looks like pemphigus. That's why you call it pemphigoid. It's a different mechanism, but it mimics pemphigus. So that's why it gets the term pemphigoid. So these autoantibodies, so the components of the desmosomes, there's two components in the desmosomes. One is called desmoglein 3 and the other one is called desmoglein 1. Okay, so if you have an antibody go and attack this desmoglein 3, okay, that's when you actually see lesions in the oral cavity with pemphigus. Make sense so far? So you have epithelial cells. How are the epithelial cells connected with each other? Through desmosomes. If you have an antibody going and attacking these desmosomes, what disease process does it result in? Pemphigus. Okay, so these desmosomes, the components of the desmosomes are two components, desmoglein 3 and 1. Okay, in order to see pemphigus in the oral cavity, desmoglein 3 has to be affected of that desmosome. Okay, and so there are 4 different types of pemphigus, subtypes. Pemphigus vulgaris, vegetans, erythematosus, and foliaceous. It's only the first 2 that can actually cause lesions in the oral cavity, the vulgaris and vegetans. Okay, but the one that's important for us is Pemphigus vulgaris. That's the one we see commonly in the oral cavity. So when we talk about pemphigus going forward, we're basically talking about the subtype Pemphigus vulgaris. And this is it's not very common. There's about maybe 1 or at the most 5 cases per million people. So this is not something that you see periodically. But the reason why this is important for you guys as hygienists is because it actually affects the gingiva. Okay, so you get this presentation clinically called desquamative gingivitis, and I'll show you pictures of that. And that easily gets mistaken for periodontal disease, okay, or gingivitis. And so that's why it's critical to know if you're dealing with an immune-mediated disease or if you're dealing with something that's inflammatory in origin. Okay, so what do we see in patients with pemphigus? How do you guys characterize these lesions? How do you describe them? This one right here. Is it single or multiple lesions? Multiple. Okay, what part of the mouth is affected? The palate. Is it both hard and soft palate? Yes. Okay. So what do the lesions look like? Do they look elevated, or do they look depressed, or do they look flat? Okay, so when you say a flat lesion, you're only talking about pigmented lesions. You don't use the term flat for this because you have a break in the continuity of the membrane, right? So this is not a flat lesion. If you look at an amalgam tattoo, that's a flat lesion. Okay, if you look at a macule, that's a flat lesion. But this one is considered an ulcerated lesion, so it's a depressed lesion. Okay, so if you have a depressed lesion, so these are ulcers, right? Erosive areas. Okay, so you have a break in the continuity of the membrane, and there's multiples of them. Okay, what's going on here? An ulcer too, right? You have multiple ulcers, but here you have a membrane on top of the ulcers. So there's a slight difference in its presentation, but there's still these extensive ulcerated lesions. Okay, that's why these conditions, they're called vesiculo-ulcerative lesions, because they start off as a vesicle or a bulla. Do you guys know what a vesicle or bulla is? So a vesicle or bulla is basically a blister that you can see in the mouth. Okay, if it's smaller than 5 millimeters, you call it a vesicle. If it's larger than 5 millimeters, that blister, you call it a bulla. Okay, so depend just based on the size, you just give it, either use the term vesicle or bulla. But basically, it means they're blister type lesions that you're seeing in a patient's mouth. So what happens is with pemphigus, they start off as blisters. They rupture and then they form ulcers. So that's why you call them vesiculo-ulcerative lesions, because they start as a bump or a blister, eventually rupture, give rise to these ulcerations, okay, which could be extremely painful for the patient. So pemphigus, one thing to remember is it affects oral mucosa, but it also affects the skin. So with mucous membrane pemphigoid, you don't see that as much. It doesn't affect the skin as much as you would see it in pemphigus. Okay, so Pemphigus vulgaris affects the skin and the oral mucosa. It's a disease that actually affects adults. Okay, so this is not something that you tend to see in teenagers or younger patient population. Okay, there's no specific gender predilection for pemphigus, so you can see it with equal frequency in both men and women. And the main thing with pemphigus are the oral lesions, right? Because I said it has both skin and oral involvement. The oral lesions are usually the first ones that arise in a patient's mouth. They're more than even skin lesions. So oral lesions are the first lesions to come, but they're extremely difficult to treat. So they're the last lesions to go. Okay. So oral lesions are the first ones that arise in a patient's mouth, but they're the hardest ones to treat in a patient. Okay. And so this is, again, more examples of pemphigus, these ulcerative lesions, right? So what you see here is, again, these extensive ulcerated lesions. They've got a membrane here, and this is on the ventral tongue. And you have lesions on the lateral tongue. So this can pretty much affect any part of the oral mucosa. So there's no site predilection here, right? You can see it on the buccal mucosa, you can see it on the tongue, you can see on the lateral tongue, ventral tongue, floor of the mouth, pretty much anywhere in a patient's mouth. So there's no specific site predilection for pemphigus. Okay, and then the blisters that the patients get in the mouth before they turn into ulcers, those blisters usually don't last too long. They rupture really quickly. So patients might tell you when you talk to them in their history, let's say I get a blister, but it usually lasts like a few minutes or a few seconds. It collapses, and then I get these ulcers, right? And when you try and look in the patient's mouth, you may not actually find a blister because, as I said, they're very short lasting, so they don't last too long for you to be able to visualize in a patient's mouth. So one of the things you can do in a patient with pemphigus is something called Nikolsky's sign. Okay, it's Nikolsky, and it's in your handout. Nikolsky's sign basically means if you have an intact oral mucosa, an area that's not affected by the disease, and you took your finger and you applied lateral pressure on that intact surface, you can actually cause a blister to form. Okay, so that's called Nikolsky's sign. So if you see Nikolsky's sign, that's suggestive that you're dealing with either pemphigus or pemphigoid, because those are two diseases where the Nikolsky sign is positive. Yes?
How sudden is that? Like immediate? Or?
Yeah, right away. So when you apply lateral pressure, you'll notice that a blister forms pretty much right away in that area where you apply pressure. Okay. So the reason why is basically because in pemphigus, the cells are separating from each other, right? So when the cells separate from each other, when you're applying pressure, you're causing this one cell to separate from another cell, and you're causing the blister to form underneath the cells. Okay. And because the part of the, and I'll show you the histology, it'll make more sense why those blisters rupture so easily. when we look at the histology. So on the skin, it can be the same thing, right? They start off as these vesicles or bullae, and then they rupture, and then they turn into these ulcerations. So far with pemphigus, what you need to remember is this is a disease that usually affects adults, right? It's an immune-mediated disease. It affects both the skin and the oral cavity, okay? And the reason why you see pemphigus is patient produces autoantibodies which go and attack the components of the desmosomes between the epithelial cells. Typically, it affects desmoglein 3, which is the major component that can end up resulting in Pemphigus vulgaris. Okay? And when you, so if you took a biopsy of pemphigus, right, this is what you're going to see. So typically, whenever you're dealing with an ulcerated lesion like that, when a biopsy is done, you never take the biopsy of just the ulcer itself, because all you're going to see is shredded areas in that, you know, wherever you took the biopsy, right? So it's not really diagnostic. So you have to take a portion of normal tissue along with the ulcer if you want to establish a diagnosis, because we want to see the transition. Where exactly is this separating? Okay, not sure why this keeps doing this. Okay, so what you see here is this is your epithelium, this is your connective tissue, and you know this is connective tissue because you have blood vessels right there, right? So now you have epithelium. So are all the epithelial cells separating from the connective tissue, or are some of them connected still? Some of them are still connected, right? It's only part of the epithelium that's separated, and then you still have some epithelial cells connected to the underlying connective tissue. Okay? So this is frustrating. I'm not sure why it keeps doing this. Okay. So this is where the blister is forming, right there. See that empty space right there? That's where your blister forms, because you have the epithelium separating part of it from the connective tissue, and part of it still is attached to the connective tissue. That's why the roof of this blister is actually much thinner. Because if the entire epithelium separated from the connective tissue, then you'll have a nice thick roof, right, for the blister. But if only part of it separated, you're only going to have, you know, a thinner roof, right? So, thank you. Get that. You need to go backwards. Perfect. So this is where you have the blister, okay? So you don't need to do that. We're done with the slide. I'll move on. Thank you, though. So this is called an intraepithelial blister formation. So when you look in your histology, there's basically a note that says that it's an intraepithelial, you know, separation, right? So you have an intraepithelial blister that forms that causes portion of the epithelium to separate from the underlying connective tissue. That's why the thickness of the roof of the blister is much thinner, and that's why the blister doesn't last too long in a patient's mouth. It collapses easily. Make sense? Okay. If you guys have any, at any point, if you want me to repeat it, I'm happy to do that. Because these are, this is a difficult concept, but it's important to understand because this is what helps you to differentiate between pemphigus and pemphigoid. And that's critical. Yes?
Obviously, within these two, the histopathologic feature is important to differentiate. But
that's correct.
During tests, is this something that you really want us to focus on? I mean, all the sections, but...
So clinically, what you need, are you looking at histology focusing on,
yeah,
or
histology.
clinically? So histology, that's the area that you need to focus on. Where is the separation happening? So if the separation, if the blister is forming inside the epithelium and only part of the epithelium is separated from the connective tissue, you will call it pemphigus. If the entire epithelium separates from the underlying connective tissue, you call it pemphigoid. Okay. And I'll show you examples side by side. So it'll... okay, so here, this histologic appearance. So this is where your blister is formed. This is your connective tissue with the blood vessels. These are some of the epithelial cells still connected to the connective tissue. Now these cells, the appearance of these cells, we call it row of tombstones. They look like a row of tombstones. These acanthalid, the cells that are still connected to the connective tissue. And then there's some cells that kind of freely float in this blister space. And these cells are called tzenk cells, these ones that you see here. T-Z-A-N-C-K, and that's in your handout. So if you see the term tzenk cells, I'm basically referring to these cells that got separated from the epithelium, and they're kind of freely floating in the blister. Okay. So whenever you have a patient with pemphigus, what the dentist is going to do is, most likely they'll have to refer this patient out, to an oral surgeon, right, to go ahead and do the biopsy. Most dentists do not prefer doing biopsies of immune-mediated conditions. Okay, so when this goes to the oral surgeon and they go ahead do the biopsy, they're going to take a portion of the normal tissue and the ulcer, and when they do that, they take 2 samples usually. Okay, one sample goes for your routine H&E staining. So this is your H&E staining right there, right? So it's pink and blue. But then they also do another test which is called immuniflorescence. Okay, so this is done in pathology labs. Okay, so you have to indicate to the pathologist that you want immunofluorescence studies done. Okay, and this is critical for pemphigus and pemphigoid, because without immunofluorescence, sometimes you cannot actually make a diagnosis of either of those 2 diseases. So there's always 2 samples that get collected, one for H&E and one for immunofluorescence. And the immunofluorescence study, when you look at pemphigus, look at how it lights up. It's basically highlighting the membrane, right, around the epithelial cells, because that's where the desmosomes are. So that's what it's doing. It's highlighting the antibodies there. Okay, the antigen and the antibody combine together, and then they highlight this area around the membrane. So this kind of pattern, it's called chicken wire effect. Okay, so it basically has this webbing kind of pattern that you see here. So if we see this, even if the histology, the H&E section is not really diagnostic, this is enough to make a diagnosis of pemphigus. If you see this, it's much more accurate. Okay, so pemphigus is actually a really difficult disease to treat. Unfortunately, neither oral surgeons nor oral pathologists end up treating this disease. Some oral medicine specialists treat pemphigus, but majority of the times you want to send them to a physician. Okay, because this is a life-threatening disease. So if this affects other mucosal surfaces, it can actually kill the patient. Okay, if it's not basically diagnosed in time and treated appropriately. Okay, so this is critical to make a diagnosis of pemphigus. So if you do have a patient with pemphigus, typically what we do is send them to a physician so they can undergo treatment with immunosuppressive drugs. Okay. So they can use like azathioprine, mycophenolate, they're different immunosuppressive drugs, but then they also use corticosteroids in combination with these immunosuppressive drugs. Okay. Sometimes what you could do is either as dentist or pathologist, we end up treating the oral lesions with a topical steroid in conjunction with the systemic steroid therapy. Okay, because that may help control the lesions, but oral steroids itself are not going to be sufficient to treat this disease. Okay, so this definitely has to be referred to a physician. There is another product that's out there that's called rituximab. This is an immunoglobulin that's given IV, intravenous infusion, and this is the one that is now used by physicians to actually treat pemphigus, and it's actually very effective. Okay, so rituximab is the one that's now used by them to treat pemphigus. So there's a mortality rate of 5 to 10%, but once it's diagnosed, the reason why people may die from this disease is actually not because of the disease itself, but that's because they are on systemic steroids for such a long time, right? So there's complications associated with systemic steroid therapy, and then that can cause mortality in these patients. Does that make sense so far with pemphigus? Because we're going to move on to pemphigoid, the next entity, okay? So pemphigoid, also called as mucous membrane pemphigoid, there's another name for it called cicatricial pemphigoid. Cicatrix basically means scar, okay? So what it means is these conditions, mucous membrane pemphigoid, when it affects other than the oral cavity, if it affects other mucosal surfaces like eyes or esophageal or laryngeal, they actually heal with scarring, okay? So, but with pemphigus, they don't scar when they heal. So there's a difference. So pemphigus, the skin and other mucosal lesions do not heal, do not scar when they heal, whereas mucous membrane pemphigoid in other locations like laryngeal, esophageal, vaginal, other locations can actually heal with scarring. But the oral lesions in both pemphigus and pemphigoid, they both don't scar. Okay, does that make sense so far? Okay, and pemphigus, remember what were the two sites we said where it commonly affects? Oral mucosa and skin, right? So skin and oral mucosa are commonly affected by pemphigus, whereas with mucous membrane pemphigoid, it actually affects the oral mucosa, but it also affects other mucosae like conjunctival. Eyes are like a common site where it actually causes lesions, but it can affect esophageal, laryngeal, vaginal, different mucosal surfaces. This is much more common. The likelihood of using mucous membrane pemphigoid in your clinical practice is actually higher than seeing a patient with pemphigus. Okay, so this is also an autoimmune disease, and remember I said the difference between pemphigus and mucous membrane pemphigoid is where do these autoantibodies go and attack the cells, right? So these basically attack the component of the basement membrane level. So the hemidesmosomes is what gets affected here. Okay, so what do we see here in these two pictures? This is something you might see commonly in your practice, right? How do you guys describe this? I'm sorry? So the gingiva appears inflamed, okay. Is there anything going on with the gingiva? Why did you think it was inflamed? There was erythema, right? So that's important. So you can actually see erythematous areas right above that the Q-tip that you're seeing there. You can see that it's actually it looks red, okay, but there's also like recession and stuff, but that's not the area we're focused on. We're looking at the gingiva here. How about this one here? It looks like gingivitis, right? Why did you guys think this looked like gingivitis? It looks red, it looks erythematous, it looks inflamed, okay? But this is actually not gingivitis. This is mucous membrane pemphigoid, okay? And this is what I mean by why, this is of critical importance to you guys, because these patients, they usually present with this kind of a presentation, mucous membrane pemphigoid. This is called desquamative gingivitis. So it looks like gingivitis, but actually if you look at the surface layer, it's desquamating. So that means it's peeling off. Okay, so that whole the redness that you're seeing is because the top layer of the mucosa peeled off. Okay, and that's why it looks erythematous or red, but it's actually not gingivitis that's doing that. Okay, so this pattern, when you see it, you use the descriptive term called desquamative gingivitis. Okay, so if I give you an example like this either on your exam or a quiz, and if I ask you what descriptive term would you use to describe this clinical presentation, what would you say? Desquamative gingivitis, that's right. And if I ask you what is your diagnosis for this, what would you consider on the top of your differential diagnosis? What would you say? Mucous membrane pemphigoid. Okay, and Pemphigus vulgaris can also present like this in your differential, and lichen planus, which is another disease that we're going to talk about, can also present like this. So those three come in your differential diagnosis. You had a question?
So how would I know that the top membrane peeled off?
Okay, I'll show you an example of how you can test to see if the top layer is peeled off or not. Let's go here. Do you see that right there? Okay, so if you take your air water syringe, okay, and you direct it at the mucosa that looks normal, and then force air from your air water syringe, the top layer peels off like this. Okay, so basically this is epithelium that's actually stripping from the underlying tissue. So this is all epithelium that's separated. Okay, so this is something, and this is extremely painful for patients, right? Because they're losing the layers of the epithelium on the top. Okay, so This is another example of discomative gingivitis. Again, this mimics gingivitis, right? So it looks really red, it looks inflamed, but this redness is basically because the top layer has peeled off, right? So there's desquamation. And the patient unfortunately doesn't have good oral hygiene, and that doesn't help, right? So these patients you have to encourage to make sure that they get their cleanings done periodically. They may have to go on a 3-month regime rather than 6 months in order to make sure that these lesions don't flare up. Yes?
So I noticed that a lot of the stuff we're learning is all red. And then when we're testing, will you give us like a scenario, a case with other information too, not just the picture?
Not just the picture. If you get a picture like this, you will be asked a differential diagnosis if there's no information, and you may be able to, give me 3 or 4 things that can look very similar to this, right? But if I'm expecting a specific diagnosis from you, you're going to have enough information that's provided that's going to help you make that diagnosis. Okay, so this is a condition, again, mucous membrane pemphigoid, also affects adults. Okay, so it basically affects patients over 40 years of age. This tend to be a little bit more common in females compared to males, and these also start off as vesicles or bulla. Okay, they rupture and then they turn into ulcers. So this is also a vesiculo-ulcerative condition, just like pemphigus. So mucous membrane pemphigoid and Pemphigus vulgaris are both vesiculo-ulcerative conditions. So that means they both start out as vesicles or bulla in a patient's mouth. They rupture and then they turn into ulcers. And these ulcers can coalesce together. That means they can join each other and then involve a larger portion. Okay. And these usually don't scar in the mouth, both pemphigus and pemphigoid. But one of the other things with pemphigoid is the Nikolsky sign, just like pemphigus, right? What was Nikolsky sign? What did we call it? When you apply lateral pressure on what? Is it normal mucosa or abnormal mucosa? Normal. So if you apply lateral pressure on normal mucosa, if you can cause a blister to form, that's called Nikolsky sign, right? Positive Nikolsky sign. And that can happen in both pemphigus as well as mucous membrane pemphigoid. Okay? So Nikolsky sign is positive in both Pemphigus vulgaris and mucous membrane pemphigoid. Okay, and so this is what it would look like. I don't know what's going on with this. Okay, so this person on a normal mucosa, lateral pressure was applied, and you could see that a blister got formed. Okay, but the blisters in mucous membrane pemphigoid, they actually last a little longer compared to pemphigus. The reason why is because the entire epithelium separates from the underlying connective tissue in mucous membrane pemphigoid. So the roof of the blister is much thicker. So that's why it lasts much longer. Okay, so you can actually see these blisters in a patient's mouth when the patient comes to you complaining of ulcers. But the other main critical thing with mucous membrane pemphigoid is the involvement of the eyes. Okay, so the big difference between Pemphigus vulgaris and mucous membrane pemphigoid is the site of involvement. Pemphigus vulgaris was skin and oral lesions. Remember, mucous membrane pemphigoid tends to be oral and conjunctival lesions. It can affect other mucosa too, like larynx, esophagus, and all of those. But the critical thing is eye lesions. The reason why is because if this doesn't get treated, patients can go blind. Okay. So 25% of the patients with mucous membrane pemphigoid can actually have eye lesions. So what do you think would be the right step for this patient? If you make a diagnosis of mucous membrane pemphigoid, what should you do for this patient? Send them to? Ophthalmology. So you want to send them to optometry or an ophthalmology because they have to get a baseline exam of their eyes to see where they are at. And then they have to be monitored periodically to see if there are lesions developing in the eyes. So what they do is, they usually start off as conjunctivitis. So it just looks red, the eyes, right? Eventually what happens is, you get these adhesions in the eye. These are called symblephrons. Okay? So basically there's an adhesion that develops in the conjunctiva of the eyes. Okay? And then what happens eventually is the eyelid actually turns inwards. Okay, and then the eyelashes actually start rubbing on the cornea. And then, so these adhesions, they get bigger and bigger, unfortunately, to a point where the patient cannot see. Okay, and then they lose their eyesight. So this is a serious condition, and it's critical that it's evaluated and patient is sent, to the appropriate specialist. Yes.
How do you pronounce that again?
Symblepharon, Symblepharon. Symblepharon. Okay, so how do we see? So if we took a biopsy of it, what are we going to see? What is this one? What's this one? Connective tissue. So what's happening here? It's separating the epithelium, right? Is it part of the epithelium separating, or the entire epithelium is separating from the connective tissue? The entire thing splits, and this is where your blister forms. So that's why the roof of the blister, the thickness, is going to be much thicker, because the entire epithelium is separated from the connective tissue. Does that make sense?
Yes.
Okay, so that's why those two, even though they present clinically very similar to each other, histologically they're very different. So in the treatment, the way they respond is going to be different. So you do, again, when you do a biopsy, you do an H&E staining and you do immunofluorescence, right? Now what's happening with the immunofluorescence study? What do you guys see different from Pemphigus?
Connecting.
Oh, bigger cells?
They're connected.
It's only at the basement membrane level where it's highlighted, right? Remember Pemphigus? It actually had outlining all of the cells, the cell membrane. If you see this, it was outlining all of the cells, the cell membrane, right? But here, it's only lining, it's only highlighting the basement membrane level, because that's where the autoantibodies go and attack the cells, okay, at the hemidesmosomal level. So this is mucous membrane pemphigoid, this kind of a pattern that you see. It's a linear pattern at the basement membrane level. Okay, so your main things to remember with treatment are referring to an ophthalmologist. You send them to an oral pathologist or an oral medicine specialist for treating the oral lesions. We can go ahead treat all of the oral lesions associated with mucous membrane pemphigoid. And the way this is commonly treated is with topical steroids. So you treat them either with clobetasol, betamethasone, dexamethasone, any topical steroid you can utilize to actually treat the oral lesions. But the main thing with patients with either Pemphigus vulgaris or mucous membrane pemphigoid is making sure that you maintain good hygiene, right? So these patients need to be followed up periodically to get their cleanings done. Because if the gingiva is inflamed because of poor oral hygiene, that unfortunately does not help with the disease process. It doesn't help the areas to heal. If the topical steroids are not successful, then I go ahead and use systemic steroids for these patients, right? But you have to be a little bit more careful. I don't think I have this in your handout, but if you want to take a picture of it, I'll include it in the PDF of the PowerPoint. It's basically a table to show you the difference between Pemphigus and then mucous membrane pemphigoid. I'll include it on your PDF for the PowerPoint if you want to use it. So what is the big difference? Is Pemphigus vulgaris, you have skin and oral lesions. Mucous membrane pemphigoid is oral and eye lesion. These attack the desmosomes. Mucous membrane pemphigoid attacks hemidesmosomes. Please no talking while the lecture is going on. It's really distracting. If you guys have something to really concentrate and talk about, let's do it after class. I would appreciate that. This is an intraepithelial blister. This is a blister that forms below the epithelium. Okay? Here the oral lesions first come and go. Here it basically presents more commonly as disformity of gingivitis, the pemphigoid. This is commonly treated with rituximab and systemic steroids. This is topical steroids and systemic steroids. This one is a life-threatening disease. So this one basically can cause blindness. Okay? So that's your major differences between mucous membrane pemphigoid and Pemphigus vulgaris. And histologically, that's your difference. Here in pemphigoid, the entire epithelium is separating from the underlying connective tissue. In Pemphigus, it's only a portion of the epithelium separating from the connective tissue. You still have some epithelial cells attached to the connective tissue. Okay. So This is a critical difference because, as I said, both of them look very similar to each other clinically, and it's hard to differentiate between them because they both can have positive Nikolsky sign, they both can present as desquamative gingivitis, they both are seen in adults, so they both can present as vesiculo-ulcerative lesions. So it's hard to differentiate clinically between these two. So you give it as a differential diagnosis, but if you have all of this other information, then you can make a definitive diagnosis. Make sense? Yes.
So, for instance, like if it was a quiz question, would we be given also the slides, what it would look like as well?
You may be given slides, or you may be given a histologic description saying that there's an intraepithelial blister. Then you should know that this is pemphigus, right? If it says subepithelial blister, then you would know that it's mucous membrane. But something, if you're expected a definitive diagnosis, you'll have enough information to make that diagnosis. Yep.
To study, some of us like to print these out and then kind of flip them. Is there a good source to get these from? Is it all from the book, or?
You can actually get it from, do you guys have Neville and Dam? There were 2 textbooks, I think Dr. Richards must have posted on your Canvas page, right? So they were, so there's one book that is actually available through the library. The Neville one, so that's actually a really good book with really good clinical pictures. So if you guys want to look at clinical pictures, like more examples, that's a great place to start. There's also another textbook called Regezi and Shuba, Regezi. He actually has really good clinical pictures too in his textbook, and that's also available through the library, and it's free of cost. So if you guys want to look at more examples of clinical pictures, those are some good tools to use, those 2 books. Okay, so let's move on to the next entity, which is Erythema multiforme. This is something that you may see in your clinical practice. Again, why is it important for you guys is because it can have impact on the oral mucosa, especially on the gingiva. You can see significant changes. So Erythema multiforme, if you look at the literature, there was an older classification scheme that they used to use, and then they had 4 diseases under Erythema multiforme that they had classified. But that's changed now. So it's basically 2 conditions that fall under this the umbrella of Erythema multiforme. It's Erythema multiforme minor and Erythema multiforme major. Okay, so they're 2 different types, minor and major, and then we'll talk about the difference, why they call them that. The reason why you see Erythema multiforme, again, nobody knows why you see this disease. It's uncertain pathogenesis. Okay. But they think that 50% of the times, if a patient ends up with Erythema multiforme, that they previously would have had either a herpes infection or a mycoplasma pneumonia infection. Okay, so a herpes infection can eventually lead to an Erythema multiforme. A mycoplasma pneumonia infection can eventually lead to Erythema multiforme. Or if a patient is on some antibiotics or analgesics, they can get Erythema multiforme after being on those antibiotics or analgesics. So 50% of the cases are tied to these 4 things. Okay, either herpes infection, mycoplasma pneumonia infection, being on an antibiotic or an analgesic. All 4 of those can trigger an Erythema multiforme reaction in a patient. Okay, there's other triggers too, like TB, like a bacterial infection. Patient, if they had a deep fungal infection like histoplasmosis, or if they had a malignancy, then that can cause Erythema multiforme. But this is an acute condition, so it's a short duration, right? Okay, so what do we see here in this picture? They look like chapped lips, right? Yeah, but so they look like they're crusted, the lips. But is that the only thing? It's red, so it's hemorrhagic, and that's a characteristic feature of Erythema multiforme, is that red chapped appearance of the lips. So it's called hemorrhagic crusting. Okay, so hemorrhagic crusting of the lips is something that you typically see with Erythema multiforme. So this is your presentation right there. Okay, so this usually, as I said, it's an acute condition. There's usually a trigger, either herpes or mycoplasma or an antibiotic or an analgesic that leads to this. And then this affects younger patients. So compared to your mucous membrane pemphigus, pemphigoid or pemphigus, This one, those tend to be more common in adults. This one is more common in younger adults. This also has a slight female predilection. It can affect both the skin and the oral cavity. Erythema multiforme. Okay, and when you look at the skin lesions, I'll show you an example of the skin lesions. This is what they would look like. Okay, what does this remind you of when you look at it? Looks like a? Okay, what else? More common.
Calluses.
Doesn't it remind you of a target?
A target, yeah.
Okay, or a bullseye. Okay, so these are called target lesions or bullseye lesions because of the clinical presentation. If you look at each of these individual lesions, they actually look like targets. Okay, so that's something that's characteristic of Erythema multiforme, these kind of skin lesions. So they can have skin lesions and they'll have mucosal lesions. Skin lesions, the term that's used to describe them is called target lesions or bullseye lesions. Okay, so they basically start off as these red patches or rings. Okay, and then they turn into bullae. Okay, and then they undergo necrosis in the center, and then they can get this kind of an appearance eventually. Okay, so but orally you have different presentations. So you get this hemorrhagic crusting of the lips. Okay, or you can get these diffuse oral ulcerations. Okay, and you can also have hemorrhagic crusting plus oral ulcerations. It doesn't have to be either or, right? So if you saw this, can you differentiate between this and Pemphigus vulgaris or mucous membrane pemphigoid just by looking at it? If this is the only picture you had? Yes? How will you differentiate?
Because it's on the lip.
So you can't get Pemphigus on the lip? You can. It's hard to differentiate if you saw something like this. A history is really important here. So what you need to do is find out from the patient how long they've had it for. Remember I said this is an acute process. So this is short duration usually. So they probably would have had it for a week, 2 weeks at the most, right? But if you look at Pemphigus vulgaris or mucous membrane pemphigoid, they're chronic diseases. That means they've had it for a while. Okay, and those lesions exist for a long time. So they can have these ulcerations. And then if the ulcers were just localized to the oral mucosa and skin, some skin, then you call it erythema multiforme minor. In order to call erythema multiforme major, you have to have, along with the skin lesions, at least 2 or more mucosal sites. One of them can be oral mucosa, but you also need to have another mucosal site involved. Make sense? EM minor, you need to have oral lesions plus some skin lesions. EM major, you have to have skin lesions plus 2 other mucosal sites. And one of those mucosal sites can be oral mucosa, but the other one has to be a different site. Okay, like laryngeal, esophageal, it could be conjunctival, a different kind of mucosa that's affected. If it does affect the eyes, they also scar just like mucous membrane pemphigoid. Okay, erythema multiforme major, the eye lesions. So they can get significant involvement like this of the tongue. So you have significant ulcerations here. So they start off as vesicles and then they ulcerate, and this is what you would end up seeing. So these are extremely painful for the patient. Sometimes if it actually affects the esophageal mucosa, they have difficulty swallowing. If it affects the respiratory mucosa, they have difficulty breathing with these patients. So just be mindful of this when you see these patients with these kind of lesions. So we already talked about this, erythema multiforme major definition. So how do we treat it? So remember we said erythema multiforme, there's usually triggers 50% of the times. What were the 4 triggers we talked about for erythema multiforme? Herpes, antibiotics, analgesics, mycoplasma pneumoniae. Okay, so any 4 of these could be a trigger for 50% of the cases of erythema multiforme. Did you have a question?
So if there was a patient that had that, you wouldn't do treatment just have them see a physician and come back?
Yes, either you send them to an oral pathologist or a physician, and they have to initiate treatment for these patients to resolve those lesions, and then they come back, and then you can, basically resume your treatment. Bless you. So what happens is bless you. So if this is, if erythema multiforme, whether minor or major, is seen because of an underlying disease process, right? Like herpes or mycoplasma, typically if it's herpes, you have to make sure that this patient goes on, acyclovir or valacyclovir. Those are antivirals, because every time they get a herpetic outbreak, they might end up getting an erythema multiforme reaction, and you don't want that, right? So you may have to put them on this acyclovir or valacyclovir pretty much for the rest of their life to prevent an occurrence. If you know there's a specific drug that's actually caused this erythema multiforme to come about, then you have to make sure that the patient is made aware of that, and they should not use it in future. A lot of times you can see this in patients with ibuprofen. Who use ibuprofen, they can get erythema multiforme response. Okay, so they cannot use ibuprofen going forward. Okay, so whatever be the drug that's identified, they have to discontinue it. If it's really extensive, you may have to put these patients, in the hospital and then put them on IV fluids. Because they have difficulty eating and swallowing, and that's their only form of getting the fluids. Okay, so they may have to be hospitalized, and then they give them some topical anesthetics to relieve the pain. But if it's a smaller area that's involved, then it can resolve on its own. You don't have to do much. It usually takes about 2 to 6 weeks, for it to go away on its own and resolve. Okay, do you guys have any questions? We're going to stop right here.
Can you repeat the 4 things? What's the infection, medication,
There are 2 infections, herpes or mycoplasma pneumoniae, and then 2 medications, antibiotics or analgesics.
Okay. I thought it was
4 things.
Thank you.
Oh my gosh.
Thank you. Oh, sunshine.
Lots of phones. There's one more phone here.
Let's take it home.
I'll take it home. That's right.